Okay, here we are in part 2 of clinical chemistry. Let's go. We're going to start by talking about kidneys. So you all know that kidneys play a major role in maintaining homeostasis. Their primary function is to control water and electrolyte levels in times of abnormal balance. So if maybe an animal's not taking in enough water, or maybe too much, that sort of thing. So they excrete or conserve hydrogen ions to maintain blood pH. Again, we've talked about why that's important. Blood pH has to be maintained in a very, very narrow range in order to make sure that all of our enzyme induced or catalyzed reactions happen as they are supposed to. Kidneys will conserve nutrients when they need to. They remove end products of nitrogen metabolism, which of course if they get built up in the body will really severely alter the pH among other things. And they produce renin, erythropoietin, prostaglandins, and they help with vitamin D activation. Very, very important, of course. There are a few primary chemistry tests for kidney function. These include urea nitrogen, which we usually just call urea or blood urea nitrogen, or BUN. Creatinine, we'll talk more about that as well. So other tests include different assays to evaluate the rate and the efficiency of glomerular filtration. And I'll go into a bit more detail on that shortly. Let's talk BUN. So urea is the principal end product of acid breakdown in mammals. BUN is used to evaluate kidney function on the basis of the ability of the kidney to remove nitrogenous waste, which is urea, from the blood. So we're checking to see how effectively the kidneys are getting rid of BUN. Under normal conditions, all the urea passes through the glomerulus and will enter the renal tubules, and then about half of it is reabsorbed. The rest is excreted through the urine. If the kidney is not working right, then not enough of the urea is actually eliminated from the body, and that increases BUN levels, and we can easily measure those. Contamination with urease-producing bacteria can interfere with BUN results. That would decrease BUN levels, and it can be easily prevented though by analyzing the sample within an hour of collecting it. So that's why timing is always important. We don't want to collect our samples and then wait a few hours and then test them. So run them as quickly as you can, and that shouldn't be a problem. There's a couple of different kinds of tests. One's a photometric test. It has an acceptable level of accuracy. And then there's a chromatographic or dipstick tests that we can use, that we often do use for blood if we're just looking for BUN. And that is a screening test. This is an example of a dipstick. Some of you may have used these in practice. They used to be used all the time. It was a really quick way to have a look at just the urea and so basically how well the body is getting rid of BUN, of the urea nitrogen. So really easy to use, just like a urine chemistry stick. And so if those of you who've been in practice may have seen these ASA sticks, we don't use them so much anymore because again they are a screening tool and usually we want a bit more information than they'll give us. Urea is an insoluble molecule, so it must be excreted in a high volume of water. So that means dehydration can cause an increase in BUN. We get retention of urea in those cases, which leads to azotemia. High protein diets have high levels of amino acids, and that's going to result in high BUN. And then strenuous activity breaks down amino acids and can result in an increase in BUN as well. Age and sex can cause differences in urea values, so just be aware of that. I have not found it to be a terribly significant determinant of high BUN. Let's talk about creatinine. Creatinine is formed from creatine, which is found in the skeletal muscle. It's a function of the muscle mass of an animal. So large animals with a large muscle mass will tend to have larger creatine and thus creatinine levels, but it diffuses out of the muscle into the blood, and the creatinine level tends to be constant in any animal, regardless of what its muscle mass is. There's basically normal creatinine for that animal, which again may be higher if the animal has higher muscle mass. Any condition that alters the glomerular filtration rate will alter the creatinine levels. We use serum creatinine to evaluate for normal renal function. Unfortunately, it's not an early indicator of kidney disease. Basically, about 3/4 of kidney tissue has to be non-functional before the levels of creatinine will rise. Luckily, there are new tests coming out, one in specific, that actually are starting to detect kidney disease earlier. I'm not covering that in this lecture, but perhaps I'll talk about it down the line. But for now, urea and creatinine tend to be the ones that we use in clinic more than any others. So let's just say they're not great tests, but they do help us diagnose kidney disease. There are a couple of ways to do these creatinine tests. There's a Jaffe method, enzymatic methods. Don't worry about it. Basically, these numbers will come out of your automatic chemistry analyzer. We'll look at the BON creatinine ratio briefly here. We don't use it that much, mostly because BON and creatinine both have a wide normal range, so the ratio isn't that consistent. You might see a GFR, so glomerular filtration rate, 4 times below normal before you'll even notice a change in the BON creatinine ratio. So we use it, it's used, I should say, in humans, but we don't use it that much in animals. It can be used to assess patient status during treatment. So if we have a baseline and we have a hospitalized animal and we need to recheck blood work periodically, say it's being hospitalized for chronic renal failure or something like that, certainly we can use it in those situations. But again, not commonly used. Urine protein creatinine ratio. Now this is interesting. It's a quantitative assessment of renal proteinuria. Basically, that means that there's protein in the urine coming from the kidney or because of loss of kidney function. So in the absence of inflammatory cells, protein in the urine does indicate glomerular disease. So that's kidney disease, essentially. How do we test it? The most accurate way would be to do a 24-hour collection. I can't imagine any owner ever doing that. It's tedious, errors are common. It means you would have to, for instance, collect your dog's urine every single time he pees within 24 hours. It's very, very hard to do that. More commonly, we do a mathematical test where we compare the urine concentration with the creatinine levels in a single sample. It's actually quite accurate and comprehensive. So we use this if we suspect that there might be protein in the urine coming from the kidneys and we just want to confirm that. It's been validated for dogs. So how do we do it? Usually we collect 5 to 10 mils of urine, ideally via cystocentesis, collected between 10 a.m. and 2 p.m. It's the best time, the most accurate sample. We centrifuge it. We use a supernatant, then obtain the protein and creatinine from the sample. This is done in a reference laboratory usually, by the way. And then we get the ratio. Healthy dogs, it should be less than 1. Between 1 and 5, we have either pre-renal or functional origin of the proteinuria. If it's greater than 5, we can say, yeah, we have renal disease. Creatinine clearance tests. Another one here would be a water deprivation test. This is not commonly done, and it's usually done to screen for diabetes insipidus. So we'll talk about that in another lecture. But if we're suspicious about the kidneys, we could potentially do a water deprivation test. We basically induce dehydration and just check to make sure that the kidneys are able to concentrate urine properly. It's controversial, like I say, and again, I've only ever used it to try to diagnose diabetes insipidus, not for potential kidney failure. If you feel like it, pause the video, read through this. It tells you how to do a water deprivation test. Not to say I've never done one, but again, not commonly used. Let's have a quick look at what we've talked about with kidneys. So they play a major role in homeostasis. Our primary serum chemistry for kidney function is going to be our BUN and creatinine. Urea is the principal end product of amino acid breakdown, so basically protein breakdown. Dehydration increases urea retention, so we can get increased urea with dehydration. Any condition that alters the glomerular filtration rate will alter serum creatinine levels. And something that wasn't actually mentioned, but I'll mention it now, Dalmatian dogs have a defect, and they actually excrete uric acid, which is what birds excrete. So interesting. Uric acid is an end product of nitrogen metabolism in birds, as I just mentioned. So that's kidneys. Let's talk about the pancreas here. Very interesting organ. The pancreas is actually two organs in one. You've got the exocrine pancreas and the endocrine pancreas, and they're held together in one stroma or body. The exocrine pancreas is also called the acinar pancreas. It's the biggest part of the pancreas. It's got an enzyme-rich juice, and that contains enzymes for digestion in the small intestine. So that's trypsin, amylase, lipase primarily. And cells in the endocrine pancreatic tissue are in little islands. They're called the islets of Langerhans. We've got alpha, beta, gamma, and PP cells in the endocrine pancreas. So approximately 80% of islets are beta and they secrete insulin. About 20% are alpha and secrete glucagon. Attach the exocrine pancreas of acinar. So the is primarily on our routine blood glucose. There's also like immunoreactivity, so the LI, and then some immunoreactivity or PX. These are all as well. TL is an expensive in a way to really test for pancreatic function. That's one that we can snap at a time. It's a really handy screening type. So amylase comes from the pancreas and in salivary and in the so of course it's a little tricky. The high most it's disease, especially also have lipase at the same time. On amylase, you really with having severe disease, so always proportionality of disease. What amylase does is it breaks down starches and glycogen in sugars, and you can actually get increased levels of amylase in the blood during acute pancreatitis, of course, or flare-ups of chronic pancreatitis, or if there are obstructions of the pancreatic ducts. Lipase, most of it again comes from the pancreas. It breaks down long-chain fatty acids of lipids, so it's responsible for fat digestion, essentially. Excess lipids are filtered through the kidneys, so levels are normal in early stages of disease. As the disease progresses, cells are replaced with connective tissue, cannot produce lipase, and gradually we get a decrease, actually, of both amylase and lipase. So amylase and lipase, as you can imagine, have kind of fallen out of favor a little bit when we're looking at pancreatic enzymes to try to determine whether we have pancreatitis, for instance. Because, again, lipase gets eliminated through the kidneys. A lot of times we don't see it going up when there's pancreatic disease. Amylase sometimes doesn't go up in response to pancreatitis in the way that it should, or sometimes it's way higher than it should be. So it's amylase and lipase are kind of they can be useful, but we don't use them a lot to look at pancreas anymore. So TLI is a radioimmunoassay that uses antibodies to trypsin. Don't worry so much about that, but no, it detects trypsinogen and trypsin. This is important because trypsinogen is produced only in the pancreas. So this is a pancreas-specific test. When the pancreas is injured, trypsinogen is released in the extracellular space and converted to trypsin, and that gets into the bloodstream. So really a great test to be specific to the pancreas. It's only available for dogs and cats though, and we can actually use it to look for pancreatic cancer. So as mentioned, trypsin is a proteolytic enzyme that aids in digestion, as are most things that come out of the exocrine pancreas. It breaks down proteins in foods. It's more readily detectable in feces than in blood, so we can do fecal analysis for trypsin. It should be there. If it's not there, that's abnormal. And this is done in reference laboratories. PLI, serum feline pancreatic lipase, or canine pancreatic lipase immunoreactivity. So that's FPLI and CPLI. These are great. These are specific for pancreatitis, and as I mentioned before, we can use them as a snap test. So we use them regularly in practice to diagnose pancreatitis. And I don't know what we did before we had these snap tests, because it used to be that we had to send away samples for the PLI tests, and then it would take a day or two to get the results back, by which time, if we hadn't already started treating for pancreatitis, then the animal was in dire straits, and if we had, then the animal was usually better by the time we got results. So your SNAP FPLIs and CPLIs are going to be kind of your best friends in pancreatitis cases. Of course, our endocrine pancreas also has several tests available, most commonly just your plain old blood glucose. Also fructosamine, glycosylated hemoglobin, and there are some other routine tests that we do that provide useful information on the pancreas, and those would be like urinalysis, serum cholesterol, triglycerides, those sorts of things. So glucose. The regulation of glucose is complex. I'm not going to go into it, frankly. Not really. Glucagon, thyroxine, growth hormone, epinephrine, glucocorticoids, these all influence hyperglycemia. They all boost blood glucose levels, right? So very complex. Insulin, however, is a hypoglycemic hormone. So it promotes the glucose flux into its target cells. What does that mean? It means that insulin basically helps sugar or glucose get into the cells. So out of the bloodstream into the cells. Pancreatic islets respond directly to blood glucose concentration. So if the blood glucose goes up, then it'll produce more insulin. So the pancreatic islets produce more insulin. If the blood glucose goes down, then the pancreas can secrete glucagon, and glucagon stimulates glucose release from cells. So basically the pancreas, the endocrine pancreas, is responsible for controlling blood glucose levels in various situations. Remember that only insulin can lower blood glucose levels. So when we're talking pancreas, hypofunction of the pancreas is your diabetes mellitus. Hyperfunction of the endocrine pancreas is hyperinsulinism. I would say I've only seen that with insulinomas, so basically insulin secreting tumors. Glucose is used to measure pancreatic function. Yes, in conjunction with other things. It's great to get test samples for glucose from a fasted animal. A lot of times you can't. Glucose drops 10% an hour once you've collected the sample if left in contact with red blood cells at room temperature. So if you collect it and you leave it on the counter for several hours, and then you test it and the blood sugar is, low, well, that would be why. Test it right away. The anticoagulant of choice to use if you're looking to do a glucose test is sodium fluoride. It doesn't interfere with the glucose. It doesn't degrade it or anything like that. Fructosamine is a really great test for those fractious diabetic cats. Glucose binds to a variety of structures, and fructosamine is a measurement of the irreversible reaction of glucose that's bound to protein, so albumin. Increased glucose levels, so basically an animal with diabetes mellitus, will have increased binding of glucose. This makes sense. So increased fructosamine indicates persistent hyperglycemia. So fructosamine will measure basically what the blood sugar has been doing over the last, 10 to 14 days. It's kind of amazing like that. So what have we learned about the pancreas? We know that it has acinar and endocrine functions. The acinar functions are typically measured on your routine serum biochemistry by amylase and lipase, which of course we've talked about as being maybe not the ideal tests, but they are useful sometimes for screening tests. There are immunologic tests available as well, so this would be your TLIs and your PLIs. Very handy. Endocrine functions, so those are measured usually with using glucose or blood glucose and fructosamine. The use of glucose in the body, remember, depends on the amount of insulin and glucagon that's produced by the pancreas. Very important to remember that. Serum or plasma has to be separated from red blood cells immediately after collection, otherwise, what happens? The glucose gets used up by those red blood cells, so it decreases about 10% per hour as it's sitting there on the counter waiting to be run. Don't wait. Sodium fluoride is the anticoagulant of choice for those. Just another note, if I am sending a sample away to a lab for analysis, a lot of times I will do a quick glucometer reading before I send it away so that I know what the glucose was when I first took that sample. Certainly I will do that in cases where I'm suspecting, say, diabetes or some other pancreatic issue or potentially liver issue. So I will always run a quick blood glucose with a glucometer before I even send it away, just so I have a good reading, just so the sample does not have time to degrade. All right, so that's it for today. Thanks.